Welcome to Part 2 of Herpes simplex keratitis Simplified. Herpes simplex affects all layers of cornea. We have covered epithelial disease. Today we will cover immune stromal and disciform endothelitis. We are clubbing these two entities because they share their etiology and management. In fact, many times they coexist. Stromal keratitis has myriad presentations. In the simplified version, we will stick to only those immune stromal infiltrates which have overlying intact epithelium. We will omit those which have concomitant epithelial defect or those which have strong component of uveitis producing hypopyon. We will also omit necrotizing keratitis. This entity resembles infective keratitis and have tendency for early perforation. We are omitting these as they require more expertise in diagnosis and treatment. We need to rule out infective keratitis. Scraping is required, and hence all these are better dealt by a cornea specialist. The cases which we will discuss today will have infiltrate with intact epithelium, which now onwards we will refer as immune stromal keratitis. This is a slow smoldering disease. So even if a general ophthalmologist is not sure and delays the diagnosis and treatment by few weeks, it's not going to cause much harm to the patient. This entity is believed to be antigen-antibody complement mediated reaction, where the viral antigen present in stroma triggers the reaction leading to inflammation and subsequent infiltrate. Now, how to identify an immune stromal HSV keratitis? Just like any other immune infiltrates, these are usually white, anterior or mid-stromal. These infiltrates don't follow any dictum, so they may be single or multiple, central or paracentral. Density of infiltrate can be variable. For example, here it is central, diffuse, but most intense at 7 o'clock. You can appreciate in slit that infiltrate is anterior stromal in location and has more cellular reaction and edema at 7 o'clock. Sometimes infiltrate is too subtle. Here even the cornea appears compact despite infiltrate. Upon healing, these infiltrates leave a scar, scarring being proportional to the density of infiltrate. Here some infiltrates have resolved and some are still active. Major problem with immune stromal keratitis is of recurrence. We will take up this topic later. One very important thing to note is that it is totally a clinical diagnosis. No lab tests are available, so we have to pay close attention to history. Rather, we must ask a leading question about previous episodes. Other helpful clues are the presence of ghost scars, deep vessels, immune ring, and most important is the presence of concomitant endothelial disease. Deep vessels can be single or multiple. When extensive deep vascularization is seen, it is usually labeled as interstitial keratitis. Long back syphilis used to be a leading cause of interstitial keratitis. Good thing is that these deep vessels may completely disappear on resolution. Immune ring can be complete or incomplete circle. This also usually resolves without leaving a scar. We must remember that all immune infiltrates look the same. It's the complete picture which leads to correct diagnosis. So if there is a solitary small peripheral infiltrate, then it is more likely to be a marginal keratitis and we should look for blepharitis. In comparison, viral infiltrates are bigger, mostly central or paracentral. Similarly, if most infiltrates are inferior, lots of superficial peripheral vascularization, please ask for history of recurrent chalazion and look for a facial features, lid margin telangiectasia, because we may be dealing with a case of rosacea keratitis. These entities will also respond to steroids, but they don't need antiviral cover. In fact, acyclovir ointment will add to surface toxicity in these cases. After stromal, coming to endothelial disease. Out of 3 varieties, disciform is the most common. Disciform endothelitis has similar etiology as that of immune stromal keratitis, with only difference that the viral antigen is most likely in the endothelium. KPs are seen in the affected endothelium and those cells don't function well, so there is lot of edema. Sometimes KPs are not visible initially due to too much of edema but becomes visible when edema reduces. So, in endothelitis, edema will always be much more than in immune stromal disease. As mentioned earlier, mostly stromal and endothelial diseases coexist. And in fact, it helps in making us the correct diagnosis. As in all other causes of immune infiltrates, endothelium is not affected. And this type of diffuse edema is not seen. We can appreciate 3 foci of stromal infiltrates even in this edema. In combined stromal and endothelial disease, on resolution, edema of endothelitis disappears but stromal disease leaves a scar. Since the etiology of immune stromal and endothelial disease is same, treatment is also same, which means topical steroids are given and slowly tapered. Whenever topical steroids are given, prophylactic antivirals are must because though these manifestations are immune and no viral replication is happening, but steroids can trigger this and lead to dendritic ulcer. Now comes the most important part. What is the dose of steroids and how are they tapered? What is the dose of prophylactic antiviral? This tricky question has confused ophthalmologists since long. One of the head study done long back has given us broad guiding principles. It evaluated the role of steroids by comparing it with placebo. Here, topical steroids were given for 10 weeks in a tapering dose. They started with prednisolone 1% 8 times a day and tapered rapidly every week to reach a dose of once in 5 weeks. Over next 5 weeks, prednisolone was reduced to 1/8 of the dose, that is 0.125%. It was tapered very slowly, particularly when it came to once a day dose. Since trial was done in USA, where topical acivir was not available and trifluridine was used as an antiviral, it was used in half the dose as prophylaxis and then further reduced as steroids were tapered. Now, adopting this as a guideline, in my practice, I start with prednisolone eye drops 6 or 8 times a day, depending upon inflammation, and then taper it. When inflammation is almost 80 to 90% resolved, I shift to loteprednol and then start slow taper. Minimum duration of treatment is 10 to 12 weeks. Regarding prophylaxis, I start with topical acivir 3 times a day and later reduce it to 2 times a day. If surface is not good, I substitute it with 400 mg oral acyclovir twice a day. It's important to know that it's no size fits all situation. So we need to adjust starting dose and taper according to response. In case of frequent recurrence, steroid taper is very slow. Another very important thing is that if you are not sure about diagnosis, don't start steroids. Heads has shown that by delaying treatment by some time is not going to harm patient. Another takeaway point is that most recurrences happen within 1 month of stopping steroids, so that period needs a follow-up. With this background, let's go through some cases. This young female came to us with history of only 10 days. Since inflammation was not much, so prednisolone was started in 6 times a day dose and acyclovir ointment in 3 times a day dose. At 1 week, improvement is obvious. Steroid tapering started. This is the picture at 24 days and further tapering done. Second case is of endothelial disease, a young female who presented with long duration of blurred vision. Surprisingly, according to her records, in the beginning she was diagnosed as having viral etiology and on 18th June she was started on oral acyclovir and oral antibiotic. Steroids were given topically and subconjunctival too, but these were stopped after 20 days. So when she came to us, it was 2 months without steroids. There was significant central corneal edema with bullae, reducing her vision to counting finger close to face. No KPs were visible. I started prednisolone eye drops 8 times a day and prophylactic antiviral 3 times a day. Vision improved to 636 within 10 days. And now steroid tapering started. In early stages, IOP is checked digitally, but after 2 to 3 weeks, we are usually able to check IOP with NCT or applanation, and it's very essential to know any steroid response as these patients will be on steroids for long period. In 40 days, edema was minimal. At 8 weeks, we shifted to milder steroids and acyclovir was reduced to twice a day. Disciform is easy to diagnose in early stages when edema is moderate and KPs are visible. But sometimes cases come very late and history is also confusing, as happened in this young girl of 12 years. She gave history of some trivial trauma and pain for last 10 days. In village, she was diagnosed as ulcer and put on cocktail of 2 antibiotic and fluconazole 4 times a day dose. I could see only edema but no infiltrate. We know that the extent of edema is proportional to the extent of endothelial damage, so which can happen with toxic agents like calotropis or with the Descemet's rupture as in case of hydrops. But in hydrops, the site of DM tear is usually visible, which was not in our case. Secondly, hydrops happens in a patient with keratoconus. The second differential was calotropis, but in calotropis we are mostly able to get history. Secondly, most of the times edema is mild or moderate. It's diffuse. It's not a localized one as we were seeing in this case. So we suspected this as disciform and started steroids in low dose since we were not sure about the diagnosis. Here we could not find any change in 3 days. She skipped her follow-up and surprisingly came up with remarkable resolution of edema with 17 days of treatment. At 8 weeks, shift to loteprednol was done. Good thing about endothelial disease is that it gives good results even if treatment is started late. And if there is no stromal component, then there is no scar. At the most, we get a deep pre-DM haze, which is usually negligible. In contrast, stromal disease always leaves a scar. Only few lucky ones have a mild scar or they have sparing of pupil. Otherwise, in many, it involves visual axis, and major problem is that it is likely to happen again and again, and episodes keep on increasing. Another patient who developed first episode in 2006, had second in 2009, recovered with treatment, third episode in 2011, fourth in 2014, fifth in 2016. So that is the reason that this is a disease which is a major cause of blindness, particularly when it happens bilaterally. Episodes keep on increasing just like a downward spiral. And this is the reason that when it was seen that oral ACV is helpful in prophylaxis of recurrent genital and orofacial disease, it was studied for ocular herpes too. This study was done to assess how oral ACV 400 mg dose twice a day can help in preventing recurrence. It was seen that in comparison to placebo, oral acyclovir in 400 mg BD dose was able to reduce recurrence of stromal disease by 50%. However, this benefit was seen only in those who ever had a stromal disease. If we give it to someone who never had any stromal disease, then it did not have any benefit. And when the drug was stopped, then in next 6 months there was no beneficial carryover effect. So in my practice, I advise oral prophylaxis to those who start having 2 episodes in a year, or in a one-eyed patient bar is even lower. It's not very expensive. We just need to ensure that there is no renal impairment. By now, we have understood that if God forbidden we are ever asked to choose any variant of HSK for us, epithelial disease should be first choice, second endothelial, but never stromal. So take home message is that there should be no rush to start steroids because we are putting a lifelong label on patient. Second important point is that always taper steroids very slowly. Third, most recurrences happen within few weeks of stopping steroids, so patient must be under follow up for at least 1 month on stopping steroids. I hope this simplified approach helps you in treating HSV cases. Thank you very much.